simulation and the simulator. So I suppose when you start looking at simulation first, you imagine that it's going to be firstly a very expensive way of teaching, and secondly that it's going to require really very sophisticated simulators. And I just want a word on simulators before we go into any more detail on this. I mean, on the left here is one of the Terminators from Rise of the Machines. These were autonomous robots with very high intelligence. Such a thing does not exist in reality. And in reality, when you even pay for the most expensive of simulators, you get this flaccid dummy that sits on a bed with a computer next to it, and it has no way of thinking for itself. It needs to be pre-programmed with a very sophisticated, well thought out scenario. And then you need to have people there who can make the correct adjustments to the simulator to respond to whatever actions have been delivered by the trainee. So actually, the reality is that the simulator itself is simply a mediator for the simulation event, and is relatively low importance when you compare it to the degree of planning and things that needs to be done in advance. So there is a spectrum of simulation. So the spectrum runs from what's called low fidelity simulation right up to high fidelity simulation. And just to give you an example of what this includes, so low fidelity simulation would be a very simple role play. So you simply, without a lot of advanced preparation, put together a role play with a group of postgraduates and kind of run through it. It's also practicing examination with colleagues. So having a group of people together and practicing examination skills. Low fidelity scenarios tend to be of quite significant value for quite junior trainees. And in general, it's going to be suited to medical students rather than postgraduate trainees. In general, postgraduate trainees tend to derive not a huge amount of value from these kinds of sort of impromptu simulation events. Mid-fidelity, so here amongst them are things like part task trainers. So we'd be all used to this. This would be the sort of the lumbar spine that you use for simulating a lumbar puncture, or the knee that you use for simulating a knee injection. So these are not by any means the entire body, and they can do a very particular task but nothing else. You then get these mid-fidelity simmans. So that was the simulator that I showed you there a minute ago. And the simman can fall into either mid or high fidelity depending on the environment that it's used. So if we were to purchase a simman for this hospital and kind of put it into a classroom somewhere and not really do anything more beyond that, it would be at best mid-fidelity. Whereas if we were to purchase a simman but also invest a lot of money in creating a laboratory that looks exactly like an emergency department or whatever it is we want to simulate, well then we'd be into high fidelity. In-situ simulation is the other thing that fits into this mid-fidelity category, and this is where you try to bring your trainee into their workplace and simulate an event within the workplace. So you are getting kind of quite good fidelity because, of course, they're right in the place where they're going to be. But I'll talk in a minute about some of the sort of pros and cons of that approach. High fidelity then tends to be when you start using things like virtual reality, and I'm going to show you a little bit about that in a minute, and when you get into using simulation laboratories. And these simulation laboratories are heavily staffed, heavily resourced, lots of simulated equipment. They usually have sort of viewing rooms where people are behind these one-way windows and all that kind of stuff. So these are very, very expensive locations, and sort of deliver a very often hyper real experience whereby it is nearly more real and more detailed than you could expect it to be in real life, and that has its own problems. So that brings us to the kind of the risks of stimulation. So this whole sort of idea whereby you get good at working within a hyper real environment, and then you come out to the sort of the lower fidelity real environment, and people often struggle to transition back out to that. The other thing to remember is that, if you get very used to this sort of simulated environment where the stakes are low, the simulation can be paused if necessary. Trying to get used to a real life where none of those things can happen can be really uncomfortable for trainees. So it is one of the limitations you need to be careful of. Simulation can be complicated while not necessarily being complex. So generally speaking, if you look at sort of complex theory is that, you know, when you take something that is complicated and then add unpredictability to it, you've arrived into the world of complexity. And that's very much the world that we operate in. So, you know, simulation scenarios can be made complicated, and the degree of complication can be increased, but nevertheless, there's always a feeling of predictability. In general, you are doing something that is reasonably predictable. In the real world, you never know when the person is going to, you know, respond aggressively or become distressed or upset, or, you know, has an anaphylactic reaction. You know, there is this total unpredictability, and people often struggle to move from the complicated world of simulation to the complex world of real life. The other risk is that trainees will actually spend time trying to learn how to use the simulator rather than learning what it is that you had intended them to learn. So if you've got a very, very complicated simulator, well, then they get very good at using the simulator. It's like learning how to play a computer game, but actually they don't particularly pick up the skills that you had intended them to learn in the first place. So I suppose in terms of fidelity, the question is there a sweet spot? And there's two ways of looking at this. You can look at the cost and the transfer of training and skills. So as we move along the x-axis and we become move into sort of higher fidelity training methodologies, we can see that you can get quite a distance along the x-axis without seeing substantial rises in cost. But corresponding with that, we get this massive transfer, you know, so we make most of our gains in terms of transfer of skills at this kind of mid-fidelity territory. And we don't have to move into the terribly high fidelity territory where we do see costs starting to rise exponentially. But interestingly, the gains really starting to plateau. Okay, so the first thing to consider is cost, and that is a consideration when we're going from a position whereby we currently don't use any simulation-based teaching. The second thing is that the sweet spot can be different depending on the trainee. So, you know, this kind of comes back to what I was saying a few minutes ago. You know, the experts, and again, you know, no matter how expert one is, it is useful to be able to go through simulations periodically to ensure that your skills are being maintained. But experts, generally speaking, perform best in quite high fidelity type scenarios. They tend to get annoyed and disengage from scenarios that don't feel in some way kind of real. But as the sort of level of experience starts to go down, then you tend to find that people are more comfortable in these sort of mid-fidelity territories rather than being stuck in the high fidelity. And actually, as you go into even students and people of lower experience, again, they often find the lower fidelity stuff less intimidating, and as you move into sort of higher fidelity stuff, they start getting frightened by it, and their gains reduce. So again, depending on the trainee, the fidelity should be adjusted. So where should we start with simulation? And actually, this is quite a big topic at the moment. So there is a national simulation strategy being developed, and I'll talk a little bit about that in a few minutes. But in terms of us, as a group of trainers in Waterford, and particularly across the South-Southwest Hospital Group, I suppose where we have identified our starting points would be, we're not going to work on the low fidelity stuff. I think the trainees that we have aren't going to benefit from that. We're going to focus on mid-fidelity methodologies, so in-situ simulation and part-task trainers as being our mid-fidelity starting points. And then the high-fidelity starting point is going to be virtual reality, and I'll show you in a few minutes what that's going to go feel like. Just to talk about in-situ simulation and what do I mean by in-situ simulation. So essentially, in-situ simulation is, you know, you sort of you commandeer one of the bays in resource at a time that it looks as though it's reasonably free, and you try and run a quick scenario that you've planned out in a lot of detail in advance, but running the risk that if a resource arrives in, that your scenario is going to be cut dead after maybe 4 or 5 minutes, you know, and this is the difficulty. This is the difficulty with in-situ simulation, is that yes, you're learning within the environment that you're going to work in. Yes, you're going to be using the equipment that you're going to be using in your real life scenario, but you are open to being interrupted at any moment. It's very difficult to set a start time, you know, so it's hard to say, oh, I'll meet you all at 4 o'clock and we'll run the scenario, because at 4 o'clock there may be 2 people in resource and that's the end of that. It's also, you know, there have been situations described where the clinical environment becomes contaminated by simulated materials. So, you know, people bring along various supporting resources. the students don't take them away, and then you've got these simulated pieces of equipment or otherwise hanging around in a real life environment. So this is a risk. There are plenty of described situations, though, whereby by running simulated scenarios in a real life environment, people have identified very significant process problems within the real environment that have been posing risk for some time and get sort of fixed through the simulation process. So there are, there are certainly a lot of advantages and disadvantages. I suppose the resource room is a particularly challenging example because, always accessing the research room is going to be difficult. And I don't think very many of us will be planning to do simulation in that sort of environment. And the reality is that you can choose in-situ environments that are a little bit easier to access and a little bit more consistent in terms of their likely availability and that kind of thing. So I guess for now, in the absence of a simulation laboratory, this is the sort of simulation we need to be trying to aim for. So when you're designing a scenario, there are a number of considerations that you need to work into your scenario. And I'm going to kind of go through them one by one just to give us a feel for it. The first is that the purpose has to be set out at the very beginning. So you have to highlight which knowledge, skills, both technical and non-technical, and attributes you want to test or simulate or demonstrate for the participants. You need to decide where the simulation is in fact the best modality. So it is very, very suitable for translating knowledge, skills and attributes into clinical practice, but it's not suited to learning new knowledge. So for example, if Liz Abernathy wants to do a session on renal physiology in the nephron, she's not going to get anywhere with simulation. Whereas if instead what she's trying to do is translate people's knowledge of acute kidney injury into the emergency department so that people start managing acute kidney injury better, then that's likely to be quite effective. So you need to decide from the outset whether in fact simulation is the modality you're looking for, and if it's not, then move away. The simulation modality and fidelity needs to be decided, and again I've kind of talked about that in a little bit of detail. I won't run over that again. The simulation setting, so whether you're going to do it in situ or whether you're going to do it in a laboratory. Now, you can set up laboratories as such here. I mean, if you book the seminar room here, it can be a laboratory for you to do simulation, and it just won't be a very high fidelity laboratory. So, you can say you're going to do it, outside of the clinical setting if you wish. You do need to set the runtime, and in general, the best scenarios have a dead stop, so they're set at 20, 25 minutes, and when the time is up, the scenario is over. You don't allow these things to run on and on and on and on, they need to have a dead stop. But when you're putting together your runtime, you need to consider that within a simulation, you can do what are called time shifts. So, the time shifts are that you can simply pause everybody within the team, and that you can sort of discuss how progress has been so far and identify maybe things that could be done better, that kind of thing. Or you can do a rewind. So something has happened, the person has managed to kill the patient in 3 minutes, and you can simply rewind to the start of the scenario again and go again. So you can build that in, but you can also build in fast forward. So, if you're in the emergency department and you wish to get a CT of head for this person, normally and ordinarily that would take X amount of time to put up the request, discuss with radiology, get the patient down, they get the scan, images up, reports, and everything else. So you're talking about a maybe 45-minute process there, but that can be condensed down to about 45 seconds in the setting of a simulation, because you have the CT available to show them, you have the report available. So when you're deciding your scenario runtime, you need to work these things in so that within your 25 minutes you're getting the maximum amount of output. Generally speaking, the best scenarios will be interprofessional and interspecialty. So it won't just be doctors in the scenario, it'll be other professionals, and it may not even just be physicians. There could be emergency department doctors, surgeons, whatever it is that's required to make this scenario work. The next thing you have to consider is the background of the learning, and this brings in the sort of the ramping phenomenon, which is really common in simulation scenarios, and it's often described as being like a snakes and ladders type of thing, whereby somebody's doing really, really well in their scenario, better than anticipated. You can simply, without them ever knowing it, put their foot in a snake and have them slide down to a much more difficult type of scenario. Whereas if you get somebody in who you had expected was going to really fly through the scenario, but is not actually showing that ability when you get into the scenario, you have the ability to kind of give them a step up and make the scenario a little bit easier for them. And again, without them necessarily discerning that anything has changed or happened. So most good scenarios will have this, what's called ramping ability within it. The way that people ramp is that they either adjust the complexity of the scenario, they adjust the expected standard for the trainee, they start to introduce occurrences of increasing rarity, they alter the time allowed, they increase what's called the signal to noise ratio. So what meant by this is that you start providing extraneous and useless information that is kind of designed, you know, to again simulate the real world, whereby you're being told some stuff that's really useful and other stuff that's not terribly useful, and by giving more noise you're making the scenario that a little bit more difficult. You can introduce distractors and conflicts. So this is, you know, the relative who's very upset, or the patient who starts objecting to the treatment, that kind of thing. So all of these things can be built into the scenario, but not necessarily experienced by every participant. They can be brought in and out by the facilitators as needed. Further considerations, the number of faculty required. So generally speaking, they speak of 3 types of faculty in order to run a scenario. You need a technician who will make sure that the simulator does what it is supposed to do. You'll get a debriefer, who is the person who at the far end will kind of go through the simulation with the individual and tell them what went well and what didn't go well. And then you get what are called confederates. And the confederates are people who are in on it, you know, so they know the script, they know what's going to happen, they know the sorts of things that the person has to do in order to progress. And the confederates can, you know, help the person, or they can make it more difficult for them as it goes along. So these are people who are in there playing a role, but who know exactly what it is that's happening in the background. The case vignette is very important, and in general, it is advised that you would base your cases on real patients, so that you don't try to construct totally imaginary patients, because they don't tend to have the same authenticity. You need to consider what's called the flow of the simulation scenario, and here it's anticipated transition. So, you know, you're going to anticipate that we're going to arrive at a sort of a key moment where the person must either do X or Y. If they do Y, we're going to get a good outcome. And if they do X, we're going to get a bad outcome. So you need to have thought about that in advance, and have this ability for the scenario to change based on whatever that key transition was. So these need to be worked in advance. Generally speaking, you need to work in a lifesaver. So this is for the person who goes in and just freezes and has, you know, it starts doing exactly the wrong things and has clearly no idea how to move forward with it. And generally speaking, the good scenarios will have ways built in to try and get that person up and running. So often it's that one of the confederates who's in on the simulation will give them a bit of advice. They might suggest, oh, have you considered a CT for this person, or whatever else. So so that's often there. There is the voice of God as a lifesaver, and what's meant by this is that the person out in the simulation control room can speak in via these microphones. So the person doing the simulation can't see them, but they can hear them. But it's really discouraged as a way to life save within scenarios. Yeah. Assessment. So the assessment within the scenario needs to be extremely structured if the purpose of the scenario is to provide a person with a result for an exam or whatever. So if you've got an OSCE, then you need to have a really structured assessment style. But it can be really quite summative if it's intended instead for a debrief. The debrief, as I've said, is the most important part, and it is improved by the provision of a checklist and by providing suggested questions. It's important, though, to remember that the simulation scenarios tend to start out their lives as prototypes, and they go through various iterations after pilot and onwards. But the mistake that people seem to make is that they never go back and amend the original documents and scenario outlines and protocols. And what happens is you end up with 6 different versions of the scenario existing, and the actual learning being diluted because it's lost its purpose. So what is advised is that there is a formal repository of these scenarios, and that the sort of the master file essentially is updated each time that there's an agreement that there's an element of the scenario that has to be changed or improved. A very brief sample in-situ simulation. I suppose I was curious to see how much work was in putting together one of these scenarios. So what I put together was a very brief scenario for somebody with stroke and large vessel occlusion. I gave myself about 30 to 35 minutes to put this scenario together to see would it be doable. And this is what I eventually came up with. So brief vignette: a 64-year-old male, hypertension, diabetes, atrial fibrillation, has arrived in resus, EMT pre-notification of fast positivity, not accompanied by his spouse, distressed on arrival, and a visible left-sided weakness. So I've built in what I feel is sort of a bit of noise, so atrial fibrillation but without medication, lists and that sort of things. We don't know whether he's on an anticoagulant, etc. The participant that's intended here is a physician trainee of any grade. The purpose is to establish a proficiency in the use of our ischemic stroke pathway. So it's bespoke Waterford-based simulation. The setting, what I've suggested here is that this is going to be an in-situ simulation performed in the ED resus, that the runtime will be 25 minutes. The interprofessional involvement will be a stroke CNS, an ED nurse and an ED registrar, and the faculty requirement will be, in this case, a consultant stroke physician for the assessment and debrief. I think the thing that's important to say, though, is that a very well devised and planned out simulation scenario is deliverable by somebody at roughly the same grade as the participants. So if they're given sufficient information around the background of the scenario, they can run it really quite effectively and get pretty much the same learning outcomes as if the debriefer is a much more senior individual. So, but that's not necessarily implementable in the first run or two of the simulation scenario. This is the checklist, and I won't go through the checklist in any massive amount of detail, other than to say that I've set 3 different levels. So I've set a beginner level, an intermediate level, and an advanced level, with the advanced person sort of expected to hit all of these various checkpoints. The beginner expected really just to hit the highlights, and the intermediate being somewhere in between. I've anticipated 2 transitions. One is where the person has administered TPA without addressing what had been very significant hypertension. And in this situation, I've identified that if they do that, that the neurological status of the patient begins to deteriorate. And a second transition is that if they give TPA without clarifying whether or not the person is taking an anticoagulant, we're going to see a further neurological deterioration. So, so these are 2 transitions. You could work in many potential transitions, but these are 2 that I anticipated. In terms of resource, I've pulled some CTs. So there's a CT with a dense MCA and loss of insular cortex, consistent with sort of early infarction. There's a CT angio, which shows an M1 occlusion. And then if a trainee were to ask for something like a rapid scan, then we have it available for them to see. We also have basic sort of resources, such as in this case, TPA being administered while the person remains very hypertensive, and then this sort of decay in their neurological status in the aftermath of that. So, you can pull these things together. This is by no means a complete scenario, but it does feel like it's the beginnings of a scenario, and it didn't take a massive amount of time to put together. The debrief that I suggested is simply a review of the checklist that was provided, a walkthrough of the UHW ischemic stroke pathway to discuss what went well within the scenario, and to specifically